Alright, so we're going to talk a little bit about cervical disc herniation. And to start, we're going to review some of the anatomy to help a patient understand a little bit more about cervical disc herniations. So we would first describe the disc, and I like to describe it as a jelly donut. We have the nice outer doughy stuff, which we call the annulus fibrosus, and then we have the jelly, which is the gelatinous portion, the nucleus pulposus. So within a disc, we have the annulus fibrous network to contain the gelatinous nucleus pulposus. And what that does is, in the body, it's used to help decrease compressive loads and to help the body overcome the compressive loads that it undergoes. So we also have anterior longitudinal ligament and a posterior longitudinal ligament that run up and down the spine on the posterior aspect of the vertebral body and the anterior aspect of the vertebral body. And these also help contain the discs in between the vertebral bodies, so they're not just moving around all over the place. So when we think of a cervical herniated disc, a lot of people call it a slip disc. And really we need to help them understand what a cervical herniation means or a disc herniation means. So what happens is you can have a protrusion of the nucleus pulposus through the annulus fibers and through the PLL into the spinal canal. And that can be a broad-based protrusion, which would be 25 to 50% of the circumference of the disc, or it can be more of a focal presentation, which would be anything less than 25%. So the focal herniation is small, and the broad base is obviously broader, it's bigger, and it would cause more problems. So with something like a focal disc herniation, it can be unilateral, either on the right or the left side, and then with a broad base it might be more bilateral just because the total amount of area that it's covering, and that would cause symptoms down the arms. You can also have a contained disc herniation versus uncontained disc herniations. And a contained disc herniation would be one that is still, it's protruding back into the spinal canal, but it's still contained within the annulus fibrosus and the PLL. And an uncontained one would be one where the nucleus pulposus breaks through the fibrous network and the ligaments, and it enters into the spinal canal, and it can migrate up and down the canal. And when it becomes more severe, it might fragment off, and that's what we call sequestration of the nucleus pulposus. So that helps us understand a little bit more about the disc and the anatomy that's involved with it. So when a patient comes into their office, they might have certain signs and symptoms, and you can start to assess them once they walk in the office. They might have an antalgic lean because they're trying to get away from the source of pain that they're feeling in their neck. So they could, if they have a disc herniation to one side or the other, they might be leaning away from it or into it, trying to pull the spinal nerves away from the herniated portion of the disc. They might also have a deep achy pain within the neck, and it can be deep, it can be sharp, and it could also have radiating symptoms. So we can check radiating symptoms, or we can check the arms with some of our MRS exams to see if it's causing any further complications for the patient. So they might have a weakness in the arm, or they might have some paresthesia down the arm that the disc is affecting. They can also have sharp radiating burning pain into their fingertips from the disc impinging on the spinal nerves as they exit the IVF. Some of the imaging procedures that we might use to help better assess cervical disc or cervical disc herniation would be an MRI. An MRI would be a good example to look at for assessing the soft tissue and to see how much the cervical disc herniation is impinging on the spinal canal. Once we look at that, we can also use a CT to further analyze the bony structures. But for most doctors of chiropractic, we're going to be using X-rays, and with X-rays we can use those to assess soft tissue and bony structures, and help us to better evaluate a disc herniation. So what usually happens with disc herniations is that it's an overtime thing. It's a type of degeneration that occurs within patients, and it's an insidious onset. It's not just a one-time deal that it just all of a sudden comes on. So over time, the disc begins to degenerate, and the annulus fibrosis, or the fibrous networks, begins to break down, and the nucleus pulposus begins to push through with all of the compressive load that the patient has been going through for their whole life. But you can also have a traumatic case in which the patient might have had a car accident or a fall from a ladder or something, and that causes the disc to herniate and push through the annulus fibers, causing some of these signs and symptoms. So once the patient presents to the office, we can check them with certain orthopedic tests to rule in or rule out a cervical disc herniation. So the main test that we would perform would be a Jackson compression test. So what we would do is we would explain to the patient to let us know if they had any pain or any radiating symptoms through the arms as we apply compressive load. So we would first do it with the patient in a neutral spine, and we would slowly apply pressure, and then we would back off, and we'd ask the patient if they had any signs or symptoms to see if their herniated disc was affecting them. If they didn't have any, or if it wasn't as severe, then we would take them to the next step, and we would laterally flex their head first to the right, and we would add compressive load slowly and steady, and then we would back off of it and ask if they had any signs or symptoms, and then we would take them to the left side, and we would do the same thing with slow compression on and then back off. And what this does is when we laterally flex the patient's head, we're decreasing the IVF on the ipsilateral side of lateral flexion, and it's causing that IVF to decrease, and it would be a cause of the herniated disc pushing onto the spinal nerve, causing more symptoms because of the decreased size of that IVF. We can also perform other tests to help rule in or out a cervical disc herniation. So one of the tests we might ask the patient to perform would be a Valsalva maneuver, in which the patient would just bear down, and that's checking for any space-occupying lesions, and that bearing down applies the compressive load onto the disc. We can also ask the patient to perform the brachial plexus stretch test, and what we would be assessing there is to see if it's solely in the brachial plexus where they're having radiating symptoms, or if that doesn't cause any problems, then it's more into the disc portion of the spine. Another test that we can perform would be a cervical distraction test, and that would help us to decrease the compressive load that's placed on the disc, and it might relieve some of the patient's symptoms and some of the radiating symptoms and signs. If we were to have this patient come into our office and we wanted to treat them, a lot of the times they're going to have some inflammation in their neck and in the tissue surrounding that disc. So what we can use is some ice to decrease that inflammation, and we could also use ultrasound or TINS to help decrease that inflammation. Another thing that we can do is some slight manipulation. As long as the patient is not in any severe pain, or as long as they're feeling comfortable, we slightly manipulate the neck and adjust the neck around the disc to help decrease their pain and their symptoms. We can also perform some pin and stretch on certain muscles that might be hypertonic on one side or the other to help our patient overcome their cervical disc symptoms and their pain, and just to help the patient get better. So, thank you.